Good evening, guys, and welcome to the lecture on heart failure. This is going to be on chapter 34 in your MedSurg book by Lewis. In its simplest definition, heart failure is the inability of the heart to pump blood to the rest of the body to meet the oxygen needs of the tissues and its organs. It's a major issue in the United States and causes about $40 billion annually to the healthcare environment. In heart failure, we can have either a diastolic or systolic dysfunction. In diastole, that's when our ventricle is filling with blood, and in systole, that is when our ventricle is ejecting blood. So we can have either a ventricular filling problem, which is diastolic, or a ventricular ejection problem, which is systolic. So when we are describing heart failure or the depth of how bad heart failure is, a lot of times we're going to use the measurement of an ejection fraction. And then if we remember back to pathophys, the ejection fraction is the amount of blood pumped by the left ventricle with each heartbeat. And in a normal pumping heart, the ejection fraction is going to be greater than 60%. So heart failure is associated with a lot of other cardiovascular diseases, and it is increasing in its incidence and its prevalence in the United States. It's actually the most common reason for hospital admission in adults over the age of 65, and there's more than 650,000 new cases each year of heart failure, and that's estimated by the American Heart Association back in 2008. The complex progressive nature of heart failure often results in poor outcomes, but one of the biggest outcomes that we're measuring with heart failure coming down to quality in healthcare is that readmission rate. So when we talk about why heart failure is increasing in its incidence and why it is increasing in its prevalence, one of those reasons is because we do have a better survival rate after cardiac events. People survive heart attacks, but they have heart failure as a sequelae to that. We also see an aging population, not even a majority, but as a big group of people are aging 65 or more in the United States, they're going to develop heart failure because this is a progressive disease and it's primarily a disease of the older population. The main risk factor for getting heart failure is going to be uncontrolled hypertension or hypertension that isn't well managed over time. So it's so important that we know the hypertension screening, that we're doing it regularly at well checks, and that we're treating it aggressively so that we don't have the sequelae of heart failure, because we just talked about how expensive it is, $40 billion annually, and how many people are affected by it. Again, a primarily older population, and 650,000 people each year. That's a lot of people that are affected by heart failure. So if we can reduce the primary risk factors of hypertension, then we can reduce the downward effects of heart failure. The other primary risk factor is coronary artery disease, and that does include MI. So kind of again going back to the why is there so much heart failure? Because our PCI is really good. We're really good at treating MIs and having people survive those, but unfortunately they can end up with heart failure. And you can see the other contributing risk factors are there, as far as diabetes, using tobacco, nicotine, obesity, high cholesterol, and advancing age. In addition to these risk factors talking about other primary causes of heart failure, they're mainly things that affect the heart directly, and we'll get into that in a slide here. So anything that interferes with the mechanisms that regulate cardiac output. So if we can think back, well, what is our cardiac output? Cardiac output has to do with preload, afterload, cardiac contractility, and heart rate. And those are all going to cause a change in our cardiac output. So any changes in these factors can lead to the decreased ventricular function and turn into heart failure. So some examples of some primary causes that cause direct damage to the heart would be rheumatic heart disease, pulmonary hypertension, putting that pressure on the right side, cardiomyopathies, valve disorders, myocarditis. Those are directly causing an abnormal functioning of that heart muscle. Other precipitating causes are conditions that increase the workload of the ventricle. So some of these could be dysrhythmias. We think of an uncontrolled AFib, a very fast heart rate that's causing excess pressure, excess pooling of blood in the heart. It's causing stress on the heart, so that can cause the ventricles to get overworked and to lead to heart failure and the inability of the body to meet the oxygen demands of the tissues and the organs. We can classify heart failure into several different classification systems. We used to always call it a left-sided heart failure or a right-sided heart failure. And I'm just going to kind of cross that out a little bit because we really don't use that anymore, even though you'll hear people say it all the time. What we want to get used to talking about is a systolic heart failure versus diastolic heart failure. So what are those and what happens with those? Well, with the systolic heart failure, again, it's an inadequate ability to empty during systole. So you don't have a good contractility. It fails to generate enough pressure to eject blood forward during systole. And in diastole, it's the inability of the ventricles to fill. So we're not having enough of that kind of preload or that filling pressure when we're in a diastolic heart failure. So talking about systolic heart failure first, okay, this is probably much more common and something we're much more familiar with. So when we talk about systole, again, we are talking about the ejection fraction. So if we want to say someone is in systolic heart failure, they have to meet the criteria of a low EF. So we said previously that an ejection fraction, an EF, about 55 to 60% is normal. So if we have an EF of 45 or less, we can say, all right, we're in a systolic heart failure now. And you can have EFs of down to 5 and 10%. So you have very, very sick hearts, but less than 45 is the hallmark and the number we're going to go for if we're saying we're in a systolic type heart failure. And the systolic heart failure, we also call it heart failure with a reduced ejection fraction, because again, if it's less than 45, that's our number. And so you will probably see going forward in the future, if you're working with cardiac patients, heart failure with a reduced ejection fraction is the new terminology for systolic heart failure. And that can be caused by increased afterload. So going back to hypertension, major cause of heart failure, can be caused by mechanical abnormalities like valvular heart disease, and it can also be caused by cardiomyopathies. When we have systolic heart failure, the left ventricle can be dilated and hypertrophied, and this weakens the heart muscle so it can't generate an adequate stroke volume. And again, going back to our physiology, stroke volume and heart rate makes up our cardiac output. So if we can't adequately put out enough blood, we're reducing our stroke volume, thereby reducing our cardiac output. When the left ventricle fails, blood backs up into the left atrium, and from there, the fluid can accumulate in the lungs, causing pulmonary congestion from the fluid leakage and the increased hydrostatic pressure in that capillary bed. On the other hand, during diastolic heart failure, we have heart failure with a preserved ejection fraction. So we're seeing signs and symptoms of heart failure such as that decreased output, pulmonary congestion, but the EF is normal. We have an EF of 60%, we'll say. Okay? And with the diastolic heart failure, hypertension is again the most common cause. Other risk factors for diastolic heart failure, older age and female gender. So females usually have more diastolic heart failure, where males will have more of a systolic heart failure. Regardless of the type of heart failure, systolic or diastolic, the end result is going to be the same. The ventricle is not pumping blood like it should. The ventricle gets overwhelmed, and then it ends up causing fluid congestion and pulmonary edema in the lungs. Here's a picture of our dilated heart chambers. So over time, with, we'll say, hypertension, we are getting so much fluid kind of pushed back that it's causing the ventricles to get bigger. When we think of physics, we think of the Starling law. When we take a rubber band, we stretch it, stretch it, stretch it, and we release it, it gets a bigger snap, and it hurts more the farther we stretch it. So we think, oh, in the heart and the fibers, that should work. We're going to stretch the heart out, and it should slam right back and give a good cardiac output. Well, right away, that does work. That's a good compensatory mechanism. But over time, with the increased afterload and the increased pressure, Starling's law becomes moot. It gets, the fibers get overextended, and we no longer have that snap back. So a dilated heart chamber is not an effective heart chamber. Here's our hypertrophied heart chamber. So this is large cell growth at the cardiac tissue, hypertrophy. And these, again, a bigger muscle is only good, you know, for winning medals and lifting weights. A hypertrophied big muscle heart is not good. It's a sick heart. It's not going to work well. So you can even see in this picture where the muscle is getting bigger and it's taking up room. It also doesn't pump as effectively. It doesn't have that good squeeze. And because the muscle is so thick, it is at increased risk of having ischemia, so not getting good coronary blood flow. And we're at an increased risk of seeing dysrhythmias with that hypertrophy. So dilation and hypertrophy in the heart are setting us up for illness, dysrhythmias, ischemia, and signs and symptoms of heart failure. So going back to more of our traditional left-sided type heart failure, we think of this as the most common form, but really it's the systolic heart failure, or the heart failure with a reduced ejection fraction, that is the most common form of heart failure. Regardless of what we call it, heart failure is going to result in a ventricular dysfunction, and when the ventricles don't work, blood's going to back up. So if it's the left ventricle, it's going to back up into the left atrium, into those pulmonary veins, and that's going to cause a lot of increase in hydrostatic pressure. So that means the fluid is going to push from that capillary bed into those alveoli, and that's going to cause congestion, edema, and as you could guess, with pulmonary congestion, pulmonary edema, we're going to see changes with our lungs' ability for the O2 CO2 gas exchange. When we look at right-sided heart failure, or we look at right ventricular dysfunction, again, that ventricle, it's not going to work. So if the right ventricle is going to not work normally and push blood forward, it's going to back up, go into the right atrium, and then we're going to see an increase in preload and an increase in fluid in our venous circulation. So signs we see on our patient here are JVD. So when they are laying down, they have bulging neck veins. We see hepatomegaly, splenomegaly, and that it would be with that deep kind of abdominal assessment piece. Congestion of the GI tract. You can see tummy pain, bloating, loss of appetite, and peripheral edema, especially that dependent edema. So seeing it in the ankles, in the lower extremities, and that edema is going to be very thick, you know, like a memory foam mattress. Again, that hydrostatic pressure is going to be high. It's going to push fluids in places where it shouldn't be. And you see the type of edema where you put your hand in it, you see all your fingerprints for a few seconds. When we're thinking of these right-sided issues, or these right-sided symptoms, I should say, the most common reason that we're ever going to see any of these is because the left ventricle or left-sided heart failure has already occurred. One of the clinical manifestations of heart failure is an acute decompensated heart failure. This is a medical emergency, and it is a rapid, sudden onset of signs and symptoms of heart failure. And so we want to get help immediately when we notice this abrupt onset of heart failure type symptoms. And the progression goes that as the ventricle is failing and the fluid is backing up into the ventricle, it also backs up into the atrium, and then it goes into our pulmonary veins. Initially, as the pulmonary venous pressure increases, we're going to have some compensatory mechanisms and some neurohormonal feedback mechanisms that's going to cause an increase in respiratory rate, but it's not going to be very much, so really we're not even really going to notice it right away, even if we're really closely monitoring our patient. Another thing we might see is a slight decrease in our PaO2, and that's in the initial stages of this acute decompensated heart failure. As this progresses, as that venous pressure increases, we're going to see the interstitial edema, and that's when we see the more we're more aware of the tachypnea. We can actually kind of count those respirations and be like, oh, they're breathing a little bit faster. And that is when the interstitial edema is starting to occur. So blood is pushing out of the vasculature into that capillary bed. And again, the pressure keeps building, keeps progressing, and eventually it'll get to alveolar edema. So when those alveoli, when they do fill with fluid, this is when it's considered the life-threatening portion of an acute decompensated heart failure, because now we're going to see manifestations of pulmonary edema. And these pulmonary edema manifestations are pretty distinct. The first thing that the patient is going to say is, I am so short of breath, I can't breathe, I can't catch my breath, I feel like I'm drowning. Those are real words that they're going to use, because as the fluid pushes out of the capillary bed into the alveoli, we're now going to have a marked decrease in our oxygen CO2 gradient. We're going to have changes in our ABG, and we're going to see patients that are feeling really ill. And so with the pulmonary edema, other things besides the dyspnea is going to be orthopnea. And if you remember, that's you can't lay flat. So inability to lay down because of the more surface volume that's kind of affected, and the dyspnea that goes along with it. Other things we'll see is JVD, and it's going to be very marked and a very specific sign for high ventricular filling pressure. Other things the patient might be are anxious, pale. They might even be cyanotic if it gets pretty bad, where we're having a lot of recruited alveoli and a large pulmonary edema, or a flash pulmonary edema. That just means really quick onset. And this pulmonary edema is most commonly associated with left-sided or left ventricular failure. Lastly, we can see in the manifestation of pulmonary edema, when we're listening to the patient, we can hear wheezing, we might even hear crackles. Although if the crackles aren't there, that doesn't necessarily mean they're not in the pulmonary edema. And this picture is on page 739 of your book, kind of going through the different stages and how pulmonary edema manifests. So here I jumped ahead of myself, but here are some of the clinical manifestations of pulmonary edema in the patient. Chronic heart failure clinical manifestations are going to be more progressive. They're going to be slow over time, and they're also going to be pretty much of a hallmark. So we can use the mnemonic of faces when we talk about manifestations of heart failure. And a lot of the symptoms that a patient is going to feel is going to be fatigue, they're not going to be able to do activities that they normally would. One of the questions that we ask our patients when they're in heart failure and how it is affecting them is, how many, city blocks do you think you could walk? How many flights of stairs could you do? And if they can't do 1 or 2 flights of stairs without getting winded, we consider that a significant change in activity level, and we would want to follow up with that with other questions and diagnostics. Other manifestations, heart failure, is chest congestion or the cough. It can be a chronic dry cough that's just always there. Again, going back to that congestion, and the pulmonary venous pressure increases. Edema, dependent edema, looking at the legs, the ankles, that's common places for that fluid to fill. And the symptom of shortness of breath. Again, there's our words that we're using: dyspnea, so shortness of breath, not being able to lay down. Paroxysmal nocturnal dyspnea. How would you ask someone about that? What is that, right? So people might give you hints about this nighttime shortness of breath, where they go, oh, I've been sleeping in my recliner for weeks, or oh yeah, my husband, he sleeps with 4 pillows under him at night. And you're like, oh, yep, as we're moving to the recliner and as we're increasing those pillows, we know that our heart failure is getting worse. There is our dependent edema, again, in the ankles, in the legs, talking back to the memory foam that I referenced to our pitting edema. So pitting is putting your finger in it and kind of counting how long does it take for this skin to kind of pop up back to normal. So we have a staging system that 1, 2, 3, 4. How bad is this edema? And with that edema, with that weight gain, that water weight gain, we tell our patients to weigh themselves every single day, because this is where we're going to see changes in the patient's signs and symptoms before it comes to that acute level where we're seeing pulmonary edema. We don't want them to get short of breath. We don't want them to have impaired gas exchange. We want to be able to catch the signs and symptoms of heart failure before it gets to that point. So we say, weigh yourself every day, watch those trends, and call us when you're noticing an uptrend. But sometimes, heart failure can be sudden. So greater than 3 pounds in a day, greater than 5 pounds in a week, we say you're having an exacerbation, and we need to kind of figure out why. Are you getting up to, and then nocturia, are you getting up more than you normally do to go pee at bedtime? So here's a picture of that pitting edema, and you can see on the left foot there's some finger marks. We just pressed right in there and our finger marks stayed. So I would say that's probably like a +4. That's a pretty severe edema. So you can see even from far away, wow, that's a pretty thick ankle right there. And then you press your fingers in there and it stays. Not gonna lie, it's kind of fun to do, but it means that your patient has a very poor heart, and we got a lot of work to do. Other clinical manifestations that we'll see in heart failure have to do with skin changes, and this can be related to the chronic or ups and downs of edema, especially that dependent edema in the legs. We might see actual pigmentation changes where they look brown or discolored on the lower extremities. We might see no hair growth on the lower extremities, or shiny skin in the lower extremities, and that's again from either having chronic swelling or the poor oxygen exchange in the capillaries in the legs. Behavioral changes can be from a variety of reasons in heart failure. One of them could be an acute exacerbation of heart failure. So if we think about the patient who had pulmonary edema and they're having impaired gas exchange, they might come off as confused. They might come off as restless, anxious, having poor attention spans. So it can be an acute exacerbation causing those behavioral changes. It can be the chronic nature of heart failure. 1 in 5 patients with heart failure also suffer from depression. Depression and anxiety have another twofold risk of mortality and higher readmission rates with heart failure. In addition to behavioral changes, let's say there's another mental illness that a patient suffers from on top of heart failure, then we have a more of a poorer adherence to the heart failure regimen, leading to more exacerbations and more worsening health. Patients might have chest pain. It can precipitate angina or that tightness in the chest. And this can be from coronary artery perfusion changes because of the decreased cardiac output, or it can be the acute diastolic heart failure or chronic heart failure causing those chest pains. And then going back again to why it's so important to weigh our patients every day is because a progressive weight gain, even a little amount, is indicative of worsening heart failure. And that is something that we can see easily and that a patient can do every day and watch the trends and be more ready to report their own symptomology there. Complications of heart failure are huge. With about 50% of heart failure patients will live 5 years after they're first diagnosed. So that's beating some cancers out for the virulence of this disease. It can be very devastating. So some of the complications can include pleural effusions. And this is when we have a fluid buildup between the two layers inside the parietal and the visceral pleura. And that obviously causes some changes in our ability to do gas exchange. This can result in dyspnea, cough, and chest pain. Another complication that we might see is dysrhythmias, and this can include atrial or ventricular dysrhythmias. And they're directly related to those changes in the heart tissue, in the stretching, which are causing kind of electrical abnormalities within the heart. With those dysrhythmias, we would want to treat them kind of depending on the type of dysrhythmia that we're in. So that could be cardioversion for atrial fibrillation, antidysrhythmics, or anticoagulants for certain dysrhythmias. In fact, with heart failure, the number one dysrhythmia is going to be ventricular dysrhythmias such as VTAC or VFib. And sudden cardiac death is a major cause of death in our heart failure population. So we have guidelines that if a patient has an EF of 35% or less, or has like the New York Heart Association class 1 or 2 for symptomology of heart failure, we're going to put in an AICD, because we know that patients with a poor functioning left ventricle or an EF of less than 35% are at very high risk to go into those fatal dysrhythmias such as VTAC or VFib. So we're just going to throw an AICD in at them to prevent the fatality of that from happening. Other complications there are the left ventricular thrombus, hepatomegaly, which we mostly see with the right ventricle failure. This can lead to impaired liver function, fibrosis and cirrhosis of the liver and the associated problems that accompany that, as well as renal failure, and that's related to the decreased cardiac output that accompanies chronic heart failure. It decreases the perfusion to the kidneys. It can lead to renal insufficiency and eventually to renal failure. So what can we do to diagnose heart failure? So diagnosing heart failure is often pretty difficult. Unfortunately, the signs and symptoms aren't super specific to heart failure in itself, like the shortness of breath, the cough. They can mimic lots of other diseases such as lung diseases or even anemia. So some of the diagnostic studies that we use to diagnose heart failure, number one is echocardiography, getting an echocardiogram or doing some nuclear imaging, stress testing, cardiac catheterization, and all of these things can help us see the structure and function of the heart muscle, the valves, and see if there's underlying coronary artery disease with that cardiac cath to see if that's the cause of heart failure. Our echo also gives us the information on ejection fraction. So with our echo, we can determine if it's heart failure with preserved ejection fraction, so again, that diastolic type heart failure, or if it's a heart failure with reduced ejection fraction. And so the systolic heart failure, or an EF of 45% or less. So how do we manage acute decompensated heart failure? If unstable, these patients can be monitored in an intensive care unit setting. If they're more stable, these patients are usually put in hospitalized, but in a step-down unit or in a telemetry unit. Regardless of where they are, we're going to want to do continuous monitoring and assessment of these patients to monitor for decompensation. So we're going to look at their vital signs, their O2 sats, and their urinary output. This gives us good, quick indications of their cardiac output. What's their blood pressure? Are their kidneys getting perfused? Are they making urine? Unstable in the ICU, we can look at different types of hemodynamic monitoring for cardiac output, such as like a Swan-Ganz catheter, so we can see pulmonary artery wedge pressure. This gives us an idea of the actual pressures in our ventricles, especially the wedge pressure is going to give us left ventricle filling pressures and how much stress is on the heart. Normally that wedge pressure is between 8 and 12, and patients that are going to be in an acute decompensated heart failure, these numbers can be, 25, 30 and higher. We can do supplemental oxygen for the patients, and if they are in severe pulmonary edema, we can even use mechanical ventilation or BiPAP. So it's continuous bi-level positive pressure airway, and that's going to reduce our preload. It's going to wash out that CO2, and it's going to help recruit those alveoli and pop them back open from our reduced surfactant and other sequelae of the pulmonary edema. High Fowler's position is an easy nursing intervention that we can do for a patient with decompensated heart failure. It not only improves the ventilatory effort or the capacity of the thorax to breathe, but it decreases our venous return to the heart, thus reducing preload in the stressed out heart. Drug therapy for heart failure, the number one therapy that we're going to use is diuretics. It is the hallmark treatment of patients with volume overload and the hallmark treatment for patients with heart failure. So the big diuretics, or the main diuretics that we're going to use, are our loop diuretics, and that is furosemide, otherwise known as Lasix, or the bumetidine, otherwise known as Butamex. Our diuretics are going to rapidly reduce the volume in the blood, and that is going to help reduce our preload. So if our preload can be reduced, our cardiac output can be improved by having an improved contractility and pumping ability of the heart. Also, it will reduce the pulmonary vascular pressures, and it should improve upon our gas exchange in that alveoli. Loop diuretics can be given IV as well as oral, and they work rapidly. Again, that's a loop diuretic, so they're going to work through our kidneys. Another drug therapy that we can use for acute decompensated heart failure are vasodilators, and these again are going to rapidly reduce our preload. Two main drugs of vasodilators that we use is IV nitroglycerin and IV sodium nitroprusside, or the nipride. So when giving these medications, we want to know how they work and what the backlash is going to be. So if giving the nipride, we want to make sure that we're in an intensive care unit setting with this medication, because it can have a profound hypotension effect, because it not only vasodilates in the venous like nitro, but it also vasodilates in the arterial end. So you can have decreased preload and afterload and an intense hypotension effect there. So you want to make sure that you have arterial blood pressure monitoring and you're in the correct setting to give that type of medication. Morphine can reduce preload and afterload, but it actually works best in decreasing the myocardial oxygen needs and improving gas exchange when we're giving it for the acute decompensated heart failure. In addition to the mechanisms of action in reducing that preload from the vasodilation and afterload, it relieves that dyspnea, shortness of breath, and anxiety that's often associated with an acute exacerbation of heart failure. Another drug we can use is the positive inotrope. So again, that's getting improving upon myocardial contractility. So some of these positive inotropes include beta adrenergic agonists like dopamine and dobutamine and DIG. So some of the beta adrenergic agonists, they work directly on those beta-1 receptors in the heart, and thus they increase the myocardial contractility. They're usually only used for short-term management in decompensated heart failure because they, in addition to increasing that contractility, they're also going to increase the oxygen demands upon the heart. DIG is available IV and oral, but it has a slow onset of action. It requires loading dose. So if we're looking for a quick treatment, DIG is not the first line treatment that we're looking for in an acute exacerbation of heart failure. Heart failure has high cost to healthcare, and it has a large number of patients that are affected by it. Thus, we want to have a well-coordinated interprofessional management for patients with heart failure. And with the new drugs and new devices that are coming out for treatment of heart failure, the way that we are going about it has changed dramatically, over even the last 5 years. One of the big changes that we've done with our interprofessional management is the use of guidelines for medical therapy that's defined by the American Heart Association and the American Association of Cardiologists. We have gone to transitional programs, cardiac rehab, and outpatient programs to help patients manage their heart failure at home. And through all of this stuff that we're doing, the main goals are to improve the quality of life for our patients, improve mortality and morbidity, and we're going to do that by preserving target organ function, maximizing our cardiac output, improving ventricular function, and overall, if we can treat the underlying cause and contributing factors, that would, take care of a lot of that. So some of the management that we see is oxygen therapy. So if a person is hypoxic, so we're monitoring their pulse oximetry, their SpO2 is less than 90%, we can give them supplemental oxygen. And this is going to not only improve their saturation, but increase or assist in meeting those oxygen demands of the tissues and the organs. Physical and emotional rest is important with heart failure. We want to teach our patients on how to conserve their energy and decrease their oxygen needs at the same time. The amount of rest that we're going to tell our patients really depends on the severity of their heart failure. Some patients with severe heart failure may get short of breath with just limited activity, and we might put them on bed rest, especially if they're in the hospital, where a patient with just mild symptoms can be ambulatory in the halls. So regardless of their activity level, we want to make sure that we are decreasing their oxygen needs, that we're monitoring them, and that we are giving them adequate recovery periods in between the activities. Okay. One major ancillary service that can help us with this is structured exercise programs such as cardiac rehab. And these are all over the country, and even in small rural towns. We just have to kind of look into insurance and programs that are available. A last management technique for chronic heart failure is using devices to help control heart failure. So patients with an EF of less than 35% are at a high risk for a sudden cardiac death. We talked about that when we were talking about EF. And so this can occur from VTAC or VFib. So one of the therapies that we can put in are the ICD, or implantable cardioverter defibrillation. And so they're automatically going to give a shock if we notice, VTAC that's fast enough, or if it notices VFib. We also can do a special type of pacemaker known as a biventricular pacemaker. And when we're putting in a biventricular pacemaker, it is specific to heart failure. Normally, when we think of putting a pacemaker in, we think we're putting it in for a bradycardia or a bradyarrhythmia, that our heart rate just isn't fast enough. So when we put that type of pacemaker in, we have one lead up in the atria, one lead down in the ventricle, and we go boom, 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 boom at a set rate. When we are doing it for heart failure, we're slipping an extra lead in there. We're crossing that coronary sinus into the left ventricle. So now we're still going boom, 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 but we're having a more synchronized depolarization of that ventricular tissue. So we're having a more effective heartbeat. And so this is called cardiac resynchronization therapy, and it greatly increases our EF and our cardiac output. Sometimes patients will need both the biventricular pacemaker and the ICD, again, depending on what their EF is and what their symptomology profile is. So here's a picture of what I was talking about with the 3-lead system. Mostly for a bradycardia, we just have one in the right ventricle, one in the right atria. But if we're going to do the biventricular pacing, we have to pass through that coronary sinus so we can get an extra coordinated effort into the left ventricle as well. We're going to get back into drug therapy for chronic heart failure now. So we talked about diuretics as the hallmark treatment for heart failure with an acute decompensated heart failure, and that is absolutely true. But we also are going to use diuretics as a chronic treatment and a daily treatment for patients with heart failure to reduce edema, to reduce the preload, and to reduce pulmonary venous pressure. Thus, we're going to prevent those signs and symptoms of heart failure, like the cough, the shortness of breath, the orthopnea, and the edema that we see, the dependent edema that we see. So the purpose of diuretics is to promote sodium and water excretion, and these directly act on the kidney by promoting that excretion of sodium and water. One type of diuretic that we can use are loop diuretics, and again, this is like the Lasix or the Bumex. And these are very potent diuretics. They work in that beginning part of our nephron in the ascending loop of Henle, and they're going to promote sodium chloride and water excretion. And this is where about 20% of our filtration occurs in the nephron, so it's really going to affect a large amount of sodium and water excretion. We do want to be careful with those loop diuretics because in addition to letting sodium and water out, so peeing quite a bit from it, it's also going to drop our potassium, our serum potassium levels. And so we want to make sure that we are monitoring those potassium levels when they're on diuretics, especially when they're like if they're IV during a decompensated episode. Other problems with the loop diuretics are ototoxicity and an increased risk of allergy. Another type of diuretic that we can use are the thiazide diuretic, and these work more in the distal tubule where it's about 10% of the nephron absorption, and they work similar where they promote excretion of sodium and water. So because they work in different parts of the kidney, of the nephron, we can use them together if we're not getting the full effect from like just the loop diuretic alone. So we can add these types together because even though they're both the drug class diuretic, they work in different parts. Other drug therapy we use, and it's a mainstay of chronic heart failure, so we have them on a diuretic. We also have them on some sort of ACE or ARB
or aldosterone antagonists. So overall, they are the RAS system inhibitors. If we think about what is that RAS, well, the renin, angiotensin, aldosterone system is what that stands for, and normally it works to maintain hemostasis. So our body's going to activate that RAS when our blood pressure gets a little low, or like our cardiac output goes down in heart failure. Our RAS is activated. And so RAS works to promote retention of fluid and sodium, and it also works to vasoconstrict to raise blood pressure. So it's a normal reaction to a decreased cardiac output. Unfortunately, over time, that vasoconstriction, that extra fluid volume, it causes problems, right? As we've been talking about this whole lecture, it causes problems with increased preload, increased afterload, and it decreases the functionality of our ventricle. So we need to stop this system, and there's many drugs that we can use at varying portions of the RAS system. So one of them that we use, the gold standard for heart failure, are ACE inhibitors. And those are our drugs that end in pril, P-R-I-L. And so that's like our lisinopril or our captopril. And so these block that conversion of angiotensin 1 to angiotensin 2. That's where those ACE inhibitors are going to work. One of the major side effects of an ACE inhibitor is going to be an intractable cough. And so many patients who can't tolerate the cough, we will put them on an angiotensin 2 receptor blocker, which works the same. It's going to inhibit angiotensin 2 from causing that potent vasoconstriction. It just works in a different way, and you don't have that cough side effect. ACE inhibitors are also associated with an increased risk of angioedema, and that can be life-threatening, causing the stridor and needing ventilatory support. So if they have an allergy to an ACE inhibitor, again, we're going to switch them to the ARB. Aldosterone antagonists like spironolactone are also very commonly used drugs to stop that RAS system, to inhibit the RAS. And so instead of holding on to sodium, our aldosterone antagonists are going to allow for sodium and water excretion, and they're going to act as a diuretic. Okay? So with all of these medications, we want to make sure that we're monitoring our potassium levels. With the aldosterone antagonists, it's going to be potassium sparing. So we want to make sure that we're watching those levels and they're not getting too high with those medications. Otherwise, that can cause other problems such as dysrhythmias. In addition to these drugs, there's one other brand new drug, well, a few years out, called Entresto. And this is a angiotensin 2 receptor blocker, so an ARB, valsartan, and it's also a neprilysin inhibitor, and that is a new kind of neurohormonal blockade that helps with the remodeling in heart failure. So it's the neprilysin inhibitor with the ARB combination therapy, and together that drug is called Entresto. It's very expensive at this moment because it is pretty darn new, but it has shown increases in mortality, MI, and morbidity rates for our patients with heart failure, and I'm guessing that we're only going to see more and more of it as we keep improving our heart failure treatments. Beta adrenergic blockers are another drug therapy we can use in heart failure, and they're going to block those negative effects of the sympathetic nervous system stimulation, and thus they're going to help with the oxygen consumption needs. We can use vasodilators, as we talked about, our nitrates to reduce preload, as well as the positive inotropic agents like the digitalis, which we again talked about with the acute decompensated heart failure. This, again, we need preload. It takes a little bit longer to work, but it's a good long-term therapy for heart failure. Nutritional therapy is a huge education piece for patients and an important part of managing heart failure. So we use the DASH diet, dietary approaches, to stop hypertension, because as we talked about in the beginning of this lecture, hypertension is the #1 factor to developing heart failure. If we're not, so we want to make sure that we're managing hypertension, and we can do that with diet. And low sodium diet is what we're going to tell them to do. We tell patients to limit their sodium to about 2 grams or 2,000 milligrams a day. And we can individualize this based on what they like to eat, cultural backgrounds, and just kind of looking at recipes together and trying to figure out an alternative to salt where they're not going to feel like they're losing their entire diet, that they're not going to be able to participate in meals with their family, but yet they are controlling the amount of sodium and the effects that the sodium can have on blood pressure and heart failure. Consulting a dietitian is always a good recommendation when making dietary changes. Other things that we can do would be fluid restrictions. This is not generally used outside of the hospital. It's usually used in the acute decompensated heart failure portion, and we tell patients to just drink for thirst. If the fluid restriction is required, we try to limit it to less than 2 liters a day. And we want to remind them that there are alternatives that they can use so they don't have to be so thirsty all day, such as sucking on hard candy, maybe using popsicles, chewing gum, something to satisfy and promote adherence to that fluid restriction. Again, the daily weights are so important when we're talking about fluid restrictions, when we're talking about fluids, and when we're weighing patients, there is a special way to do it. They have to weigh themselves in the morning or at the same time each day. We don't want the nutrition, the food intake, the water intake to affect our weight. So if you're going to weigh yourself, I say weigh yourself right away in the morning. Go pee, be in your small clothes or your pajamas, hop on that scale and write it down, and watching trends. So if we see a weight gain about 3 pounds in a couple days or 5 pounds in a week, we can see that we're having deterioration in our body's ability to get rid of that excess fluid, and we want to notify our healthcare provider right away before it gets to the point where we need hospitalization, feeling short of breath, and having those other clinical manifestations such as dyspnea, orthopnea, fatigue, etc. So planning in heart failure, our overall goals are going to be, let's decrease our symptoms. Let's have no complications related to heart failure. We want the patient to be compliant and adhere to the medical regimen, and increase in their ability of activities of daily living as well as exercise tolerance. Nursing interventions include these basic principles of care. Heart failure is a progressive disease. It is mainstayed by usually having the patient experience 1 or more episodes of a decompensated heart failure, with more and more of those decompensating heart failure episodes occurring, after 5 years or near the end of life as the heart failure progresses. So it's important for us to establish treatment plans and quality of life goals with the patient. We want them to have symptom management controlled by themselves. We want them to be as independent as possible. So we want to teach them those self-management tools, such as doing a daily weight, such as following and adhering to the drug regimen, and following diet and exercise plans with the aid of restricting salt, maybe water, and going and following a cardiac rehab or a structured exercise program. Along with that, we want to conserve their energy, talk about things that they can group together or do together, talk about rest breaks to improve their quality of life. And lastly, we want to maintain support systems because that's going to be essential to the success of the entire treatment. Nursing interventions for acute care is going to be that we're going to monitor the respiratory status. Okay, administer oxygen therapy so we can decrease those oxygen demands on the heart. Again, doing the semi-Fowler's position. We did that for the ventilatory effort and increasing the thoracic capacity to take those deep breaths. Monitoring hemodynamic status. That depends on the severity, obviously, of the patient. Doing our daily weights, improving on self-management, doing intake and output, administering drugs, and monitoring for our edema. With ambulatory and home care, again, we want the patient to take responsibility into their own hands. This is a progressive disease that isn't going to go away. So they need the tools to monitor their symptoms at home. They need to know when to call, and they need to know how to manage their care. So first off, we can explain to the patient or their caregiver what has occurred. This is heart failure. This is why it can occur. This is probably why your heart failure occurred. And then we want to help them adapt to those changes. You might have a decreased exercise tolerance. Here's a cardiac rehab facility near you. These are things that you can do to manage your heart failure at home. These are the drugs that you're on. This is how you should take them. You should weigh yourself every day and call me, or call your cardiologist if you're having issues. So again, we want to give them those tools to do the work at home. So teaching, absolutely need to know those signs and symptoms of heart failure exacerbation. So what would you tell your patient? What are you going to tell them to look for? So first off, early detection. Is your weight going up? Are you up 3 pounds in a couple days? Are you up 5 pounds in a week? Are you sleeping with pillows? Do you have difficulty breathing going up a flight of stairs and you didn't have that before? So you're looking at exercise tolerance. And we want to give these patients, hope and optimism. So we can have a positive outlook on a chronic health problem as long as we work together to maintain adherence to the regimen and knowing that they have the tools that they need to manage their heart failure at home. Ongoing monitoring is, again, teaching the patient what to report. This is what you need to know and when you need to call me. We want to make sure that we know the importance of regular follow-up. So the better relationship a person with heart failure can have with their healthcare team, the better they're going to be managed, and that might be medication management, that might be exercise management, and it might just be a good sounding board to ask questions to. Health promotion is important in heart failure. We want to let them know about upcoming vaccinations, what their vaccination schedule looks like. Yearly influenza vaccines, we know that's coming. Zostavax, looking at a shingles vaccine. And then looking at reducing our risk factors. So what's the #1 risk factor for heart failure? It's hypertension. So again, looking at our DASH diet, using medications to reduce hypertension, talking about the importance of taking those medications or making risk factor modifications to reduce that high blood pressure so that our heart failure does not progress quickly. And so how do we evaluate that we're doing the right things for our patient? Well, we're going to monitor vital signs. Are they stable? We're going to monitor weight. We're going to monitor how they're feeling. Are they short of breath? Do they have that exercise tolerance? And we can also monitor their pulse oximetry. Home health nurses can really shine in patients with heart failure, when, especially if it's a new diagnosis or a sudden diagnosis. Patients are usually going home on 5-6 brand new meds. This can be overwhelming for them. So having a home health nurse to even set up the medications could be helpful. Having them check those weight logs every day, making sure that they're getting the, up and moving and that they can get to those appointments is important. So using resources to help patients learn those tools is so important. And there are awesome new apps out there. I want to say it's just like heart failure. I have it on my phone. I'll have to check it. But patients, I mean, everyone has a smartphone, it seems like. So we can show even our oldest individuals these apps, at least try it and say, you can sync with me on this app and I can see your blood pressure every day. You can take it 6 times a day. It'll upload to me. You can send me your weight. And other cool things are the like medical grade Fitbits. I mean, those are awesome because you can get an EKG off them, you can get pulse oximetry, and you can kind of drop in on your patient throughout the day to check on them, especially if you're starting new medication managements or you're uptrending your Entresto, that new neprilysin inhibitor / ARB. Here's a few questions for you guys to ponder after kind of reading through the material and listening to the slides. So I can post the answers maybe later this week and a little bit of rationale to go through. So think about ABCs, what would you do first? So we want to really see your prioritization here. So kind of reading through it, you have lots of time to do these because it's just practice. So thinking, what is that answer really asking and what's it saying, and is it really true for this question? So this one, I think they're all good. This one's kind of a good thinker one. This one, again, we're thinking, what kind of drugs are those and what should I be monitoring for? What's the most important? And then lastly, what would you do and what do you think is happening in this scenario? So thank you so much for listening, and I look forward to our meeting on Friday.